Session. One of the things that's always been interesting to me in residency is determining when to provide reassurance to patients of various disorders and when we need to do additional workup or be concerned. And then in the event that we do need to be concerned, the sorts of counseling we provide patients, the resources that we can utilize to achieve a definitive diagnosis, and hopefully we can glean some of those pearls here discussing bone disorders. So I apologize. I've had this frog in my throat for 2 weeks. Hopefully it doesn't overcome me as we talk. But some of the things I'd hope we'd be able to discuss today would be identifying common benign tumors and at what ages we might see them, as well as some of their malignant counterparts. I also hope that we could differentiate benign growing pains from pathological bone pain. And that's crucial because so many kids will come into the clinic with complaint of unusual pain that wakes them from sleep. And we need to be able to determine whether or not we provide reassurance or if we need to do additional workup. Then primary cancers that start in other places and may migrate to bone, highlighting a few of those, as well as workup when we do suspect a bone lesion that needs to be identified. And then we also want to discuss a little bit of counseling of patients. And I won't belabor that too much because it's more of a personal thing, but some techniques that I've learned from preceptors and from medical school have helped me as I've discussed difficult diagnoses with patients. So people come in with bone pain. The bones are aching. That lady probably had rheumatoid arthritis, though, not true bone pain. So here's a quick clinical vignette. 35-year-old female comes to clinic. She's got persistent bone pain in her legs and her back. It's been gradually worsening over the past few months, deep, aching, and she complains of moderately significant fatigue and lightheadedness. No recent trauma, fever, or weight loss. Medical history is unremarkable, and she's not taking any medications. She's a healthy 35-year-old. Physical examination reveals tenderness over multiple long bones without any obvious signs of inflammation. There's no joint swelling or redness noted. So where we begin with something like this, we've already done our physical examination. We don't find any focal spots that really concern us, but it seems there are multiple sites of maybe pain or tenderness. Some inflammatory disease appears to be going on. We could either order a bone marrow aspirate, that seems a little aggressive right off the bat, refer the patient for a bone scan. Again, we're not there yet. Prescribe analgesics for pain relief and schedule a follow-up. We could try that. That might be a reasonable idea. Order a rheumatoid factor. I think that actually might be a high-yield blood test, or evaluate a CBC. And there are actually a couple of answers here that I think are simultaneously correct. If we were to go back for this, I think that we would be reasonable to suggest a rheumatoid factor and probably a CBC. Oftentimes, patients like this do have an underlying inflammatory condition, and I would think that you would have abnormalities on CBC that could be elucidated, and a rheumatoid factor might likely yield some insight. So there are a lot of common and less common causes of bone pain. So common causes, like the lady in Star Trek or Star Wars right at the beginning, barometric changes. When a storm is coming, certain people with joint pain can feel the changes in barometric pressure. Viral illnesses can cause pain, as well as things like Reiter syndrome, overuse, patients that have shin splints, growing pains. We'll get to that one a little bit later. Various types of arthritis, especially rheumatoid arthritis, can cause bone pain, particularly joint pain, but it sometimes extends. And then muscle strains, ligament sprains, bone contusions, tendinitis, anemia. A lot of benign growths can actually be painful, but don't necessarily mean malignancy, though oftentimes we associate bone pain with malignancy. Pregnancy causes a lot of pains. One of them is bone pain, inactivity, and non-accidental trauma, or NAT. And then we have less common causes that are malignancy, Paget disease, sickle cell crisis, hypertrophic osteoarthropathy, fibromyalgia. There's other things that we may yet see that should be kind of in the back of our minds, but not necessarily at the forefront of our differential. So here we've got a mother who brings her child into clinic, reporting recurrent illnesses of leg pain. Child wakes up in the middle of the night complaining of aching pain in both legs, mostly around the knees and the thighs. Pain's not present in the morning, but sometimes occurs in the afternoon. Mother notes the episodes have been occurring intermittently for a few months. Child is otherwise healthy, no history of trauma, no recent illness, no signs of joint swelling, redness, or tenderness. Child is active and has normal growth parameters. The most likely explanation for the child's recurrent nighttime pain, growing pains, spoiler alert, I think that's the right answer, juvenile arthritis. Less likely, acute lymphocytic leukemia, vitamin D deficiency. We don't see any abnormalities in bone structure or osteosarcoma. Child's not in the right age range for that. Growing pains. So typical timing for growing pains is later afternoon or nighttime. And this is one thing that we associate with B symptoms of malignancy, but pain that wakes somebody from sleep. In the case of growing pains, that's actually a red herring. Oftentimes, children will wake up with the bone pain, but it will resolve by morning. So it's not something that sticks with them. It's usually bilateral, whereas much malignancy is not bilateral. It's often unilateral. Sometimes they'll also complain of nausea, some tummy pain. They can have headaches, but it will classically not alter their gait. It's not pain that is structurally significant, meaning it's not affecting their ability to ambulate or to play at the playground, to have normal activity. Sometimes hot pads help children. Got to be careful with how hot they are. And then analgesia, child's Motrin, Tylenol often help the pain. Whereas more ominous bone pain is usually refractory to those analgesic measures. And then typical growing pain is usually the lower extremities. And ominous pain can be in the lower extremities, but often is elsewhere. So if we have the following features, I think that additional workup is typically warranted. If the pain is focal or unilateral, and by focal, sometimes you also see inflammatory changes at the site of the pain. Worse after rest, aggravated by specific activities. And this can be even benign things such as just walking or typical childhood activities. Accompanied by systemic symptoms, that's usually a big red flag. And then if it worsens or persists. In children's growing pain, it can persist, but it really shouldn't worsen typically. Bone lesions, we can categorize them a number of different ways. We have bone lesions that are either benign or malignant. And I will say there's orders of magnitude that benign lesions are more common, but we need to know about the malignant ones and how to differentiate the two. Soft tissue, periosteal, osteolytic, osteoblastic, primary bone lesions versus metastatic tumors. And again, they're much, much more commonly benign than they are malignant, but we need to know about the malignant ones. So here's a little bit of a differentiation. More benign sounding history. A 35-year-old comes with past medical history of hypertension, hyperlipidemia. He's got a lump on his leg he noticed a few weeks ago. No pain from the mass, no fevers, recent illnesses, no weight changes, no change in appetite. Immobile, non-tender, well-circumscribed, small, proximal tibia, no surrounding inflammatory changes. Very benign picture. Sometimes these still warrant a little bit of extra workup, and we'll get to that a little bit later, but that's a much more benign sounding history than the following. Same age, 35-year-old male, past medical history of hypertension, hyperlipidemia. Again, a few weeks, but the pain that he has from this mass, so first now it's painful, and it's not alleviated by ibuprofen. 8-pound weight loss, big red flag. Immobile, mildly tender, well circumscribed, and it's on the proximal tibia still, but there is surrounding edema and erythematous skin changes. Describing your lesions is also crucial, and this is important for documentation as well as for other providers who may see this patient too. We want to know, is it firm or is it somewhat fluctuant? Is there surrounding swelling? Are there changes otherwise in the soft tissues? Is it painful or painless? And is it immobile or mobile? This can be hard to differentiate because there are layers to the skin and subcutaneous tissues that it may be residing in. A lesion that is attached to or arising from the bone will be immobile. You're not going to be able to move it around. But sometimes we'll be fooled by lesions that are actually intramuscular that also may appear immobile, but upon movement of the muscle itself, sometimes those lesions will actually move relative to the underlying bone. And then you have lesions that are more in the subcutaneous fat that are very mobile, or in the skin itself, the dermis, that may be mobile as well. If ever you're concerned about a bone lesion, an x-ray is a very good way to characterize what you're working with. And typically, radiologists can detect and predict what histology might accurately be. It's a very low cost, doesn't have a big side effect profile, low risk compared to some of the other, like CT scan, which is a series of x-rays, as you know. Things like MRI, far more expensive, but you get a lot more information out of them. There are times that that's warranted. Again, contrast can help. Vascularity, necrosis, it really identifies what kind of a lesion we're working with. CT scan is also useful if you feel you have multiple sites and you're concerned about a possible metastasis. I'll share a story about that a little bit later. And then blood work, always a good idea to get a complete blood count, metabolic panel. And then if you're trying to differentiate between a primary bone lesion and maybe other causes of high calcium in the blood, parathyroid-related protein is a useful biomarker to remember. So here's some common radiographic findings in a bone lesion that we would be concerned about. So I think they're very, very easy to recognize when we see them in the context. So a sunburst pattern, it seems like there's a focal center here, and then it spreads outward from that primary point. That's a concerning bone lesion. There's something malignant under there. Similarly, Codman's triangle, this is difficult to see, but underneath here, you see that the lesion is actually lifting the periosteum, meaning that this is arising from within the bone, within the cortical matrix of the bone. And as the lesion expands, it lifts the periosteum with it, and it's growing so fast that your bone does not have time to put down fresh periosteum underneath. So what you see is a raising of that outer layer of the bone off of the underlying cortical structure. We'll get into a few that are common by age. For young kids, a number of different lesions can be detected. Endochondroma, it's seen throughout lifetime, but oftentimes seen in childhood. I won't get much more into that one, but I wanted it to be on your differential and something that you might want to do some more research into and look up. Osteogenesis imperfecta, usually we see those in children who have numerous fractures without really a known underlying cause. And tragically, many of those families go through a really difficult time because law enforcement and medical providers have to differentiate between non-accidental trauma and osteogenesis imperfecta. Giant cell tumor of the bone, it can occur in children, more common in older ages. Fibrous dysplasia, osteoid, osteoma, that one's more common in children. And we'll get more into that one later, but that one actually is a benign lesion, or typically benign, very limited malignant potential, but some. And that one is usually a painful lesion. Usually, however, that lesion will respond to NSAIDs. People will feel better taking aspirin or Motrin. It usually relieves the pain, whereas some of these other ones, such as neuroblastoma, rhabdomyosarcoma, primary bone lesions such as osteosarcoma, those do not usually respond well to NSAIDs or Ewing sarcoma. We'll get into that one a little bit later. So enchondroma, again, any age, it arises from the cartilage, which remember chondro, cartilage, often seen in the hand, young ages, and usually isn't painless. Oftentimes these will recur and spontaneously go away, but we want to differentiate between an enchondroma and a low-grade chondrosarcoma, which can sometimes hide within these lesions. And if they're low-grade at first, they grow slowly, and that's usually reassuring, but oftentimes this does warrant follow-up. Fibrous dysplasia. This is a really interesting disease that's often found incidentally as part of workup for another condition. Many of these patients are asymptomatic, but some do have pain, and it's usually in the axial skeleton. So it can be in the long bones, but sometimes you see facial changes. It can affect the sutures. And all it is collagen deposition along the fibrocellular matrix that doesn't line up with your typical bone. It causes some structural changes and can cause fractures because it's actually weaker than the surrounding bone. It's not the same well layered bony matrix. If the patient doesn't complain of symptoms, we can just do routine follow-up. We should follow up, however, but symptomatic usually requires some form of treatment, whether to prevent bone resorption in the bisphosphonates category, or sometimes surgery is required on long bones to prevent fractures. Osteoid osteoma. This is one that I saw in the clinic that a patient had pain, but it got better with the use of aspirin or Motrin. This just required follow-up for this patient. Usually there is no swelling, but sometimes it can. My patient did not. And they usually go away on their own, and my patients did. And then there's one, rhabdomyosarcoma. Again, leaf Raumeni neurofibromatosis, usually associated with some kind of underlying syndrome. Very young age is often when this is seen, sometimes as early as birth. Cluster of grapes is the classic one we all learned from STEP, but a painless, enlarging mass, and sometimes hematuria. So in a child with hematuria, we often think of benign causes for that, but here's one that we have to rule out. A little bit older, Ewing sarcoma is one I want to highlight for sure. That one is a little bit more common than some of its cousins, but chondroblastoma, osteoblastoma, and osteosarcoma. So osteochondroma is an interesting one, and it reminds me of like cutaneous horns. It's a very different process, but it resembles that on radiography. So it's very, very common that these grow on bony tumors. Sometimes it can be related to trauma, but the underlying cause is usually not really well understood. They don't often undergo malignant transformation, unlike the cutaneous horns, which typically have a squamous cell carcinoma sitting at their base. But sometimes they can be symptomatic. They can cause pain. They cause sometimes some trauma to the underlying tissues. And characterizing them with a radiography is a really good idea. Ewing sarcoma, one of my best friends in high school actually had this when we were younger. So very common as far as malignant bone tumors go. High metastatic recurrence. Thankfully, my friend did not. His was in his fibula and was excised without recurrence. The classic finding for this will be pain and stiffness, as well as soft tissue inflammation. So they'll have a lot of tenderness and often have erythema swelling at the site. And it's very often and most often unilateral. Radiography, you see that we have this moth-eaten appearance. It looks like there's chunks missing here from the center right down from the head of the fibula. Osteoblastoma, and it makes sense why it's called that. We have destruction within the middle of the lesion here. Very rare, oftentimes seen in the axial skeleton, but they can cause problems with pathological fractures. It's just not the same strength when you have loss of bone matrix. And then osteosarcoma, common at the metaphyses of long bones. We often confuse like, okay, how do we differentiate between the growth spurts and maybe pain at the site of the metaphysis? So this is one that sometimes hides within other benign pathologies. So can occur at activity, can occur with rest, and classically, as opposed to something like a benign growing pain, this will cause changes in gait because of the pain. Alkaline phosphatase is typically elevated, LDH. This one needs to be worked up a little bit more extensively, and it has a poor prognosis. A little bit older, kind of towards middle age, older young adults versus young older adults. Chondrosarcoma, that's for more of the elderly age, middle age. Aneurysmal bone cyst. This is the one that's the reason why I said we need to work up osteoblastomas And the the earlier one, I'll go back in a minute, but this can be a problem because it does not self-limit its growth. Oftentimes, it lays down these highly vascular networks, and pathological fractures are almost guaranteed as it grows large enough. And then the unicameral bone cyst, this is the one that we have a differential with on the aneurysmal bone cyst, that it typically doesn't cause pathological fractures. But differentiating those two is important because we need to treat the one, but observe the other. Fibrosarcoma, it's often in adults. Giant cell tumor of the bone. These are, again, things to keep on your differential for patients in this kind of middle age category. Bone contusions. I have a patient with this actually, where she had fallen down a rung on her stepladder and hit her tibia. And she had this very firm 2 to 3 centimeter mass that remained after the swelling went down and after the bleeding and the scabbing from the actual trauma. Not present before the trauma. And hers took years to go away. Eventually it did, but it was non-tender. It just present, didn't expand, just stayed the way it was, but related to trauma. Giant cell tumor of the bone. This one is related to gene mutations. They're usually by the knee, and they have a good potential for aggressive or malignant behavior. Those need to be excised, and typically they put down some cement and putty to replace the section of bone they remove. But these ones are classically painful. Not necessarily malignant, at least at first, but have a high potential to do malignant things down the line. So here you can see pre-op, we've got this patient who has bone pain by the knee, and after removal, cement to strengthen the lesion. Pseudocyst of the bone, again, another one that's typically an incidental finding. So low stress bone lesions, oftentimes seen with patients with diabetes, can happen with venous stasis, changes of the lower extremities. And these can go away on their own, but oftentimes they'll remain and won't really cause problems for the patient. Another one, though, that you need a differential between this and an aneurysmal bone cyst, because they can look similar on radiography. Sometimes doing a biopsy is not a bad idea. And then for older patients, multiple myeloma, metastatic bone lesions, primary tumors from other sites, osteoarthritis can cause some changes, and then Paget disease of the bone. Multiple myeloma, we had a patient in the hospital come in with typical B symptoms. They had weight loss unintentionally. They had a lot of really uncomfortable bone pain that woke them from sleep. AKI, and they were diagnosed with multiple myeloma. They had it in numerous places. And their prognosis can be good depending on the pathology underlying it. Chondrosarcoma. This one is a rare condition as far as bone cancers go. It's the third most common primary bone tumor, but not seen particularly often. It's mostly in older adults, and it is more slow growing, can take months to years. This one typically has soft tissue changes and inflammation as well. And then Paget disease of the bone can cause problems with hearing. It can cause disordered bone structure wherever it occurs, but is most commonly axial skeleton in origin. Here's just some of the images from Paget disease. You can see changes in the various axial skeleton, and then we do have some peripheral changes as well. Then just a couple of highlights about lesions. So if we're thinking about regions of bone and what might be present there, so proximal bone or ends of long bones, chondroblastoma, again, you think chondro, cartilage, giant cell tumor of the bone, typically found by the knee, aneurysmal bone cysts, these can happen anywhere, but typically along the epiphysis, osteochondroma, and then more down the shaft or the diaphysis of the bone, osteoid osteoma, Ewing sarcoma, like we saw earlier, osteosarcoma, fibrous dysplasia, and then enchondroma. But this one's tricky because, again, it can cause changes along the epiphyses as well. And then for low stress sites that don't take a lot of bone strain, pseudocysts. And then metastatic bone lesions. Here's one you think, okay, there looks like a moth-eaten appearance as well. This is an osteolytic lesion, um, possibly multiple myeloma, but other lesions can cause this as well. So the most common ones for men are prostate cancer that metastasizes to the spine, and for women, breast cancer that metastasizes to the bone in various sites. It sometimes can be difficult if there's not diffuse lesions to determine whether it's a primary tumor or a secondary tumor without biopsy. Usually that's the case, is some biopsy is required, but oftentimes if you do significant workup, patients can be identified by their primary tumor before you need to go digging around in the bone. One of them we had in the hospital recently actually was one who had no symptoms until 3 weeks prior to admission, when she began to have dizziness and loss of balance. CT scan of the head showed a bunch of lesions throughout the brain, and that one was clearly a metastatic disease. And then we did a skin exam because oftentimes skin cancer likes to metastasize to the brain. But we also did radiography or CT scanning of chest, abdomen, and pelvis, and she had a primary lung cancer. In this case, small cell carcinoma, but squamous cell carcinoma of the lung often likes to go to bone instead. I like this little graphic. This just shows different lesions and where they might be found. Ewing sarcoma, again, you see kind of in the diaphysis, osteochondroma, and you find that various lesions have typical distributions where they usually arise. So a 12-year-old boy comes to clinic with a 2-month history of right leg pain and swelling. So we're again in a similar age where maybe we see growing pains, but the problem is this boy has swelling. The pain was initially mild, but progressively worsened, especially at night. Low-grade fevers, fatigue. Mother denies a history of trauma, but there's a tender, firm, immobile mass over the right midshaft of the right femur, and mild overlying warmth and no erythema. We have an elevated ESR, leukocytosis, and an X-ray shows a moth-eaten lytic lesion with periosteal reaction, onion skinning. Ewing sarcoma is the likely diagnosis here. And again, we talk about the moth-eaten appearance. The age range is just about right. He's a little on the early side, but this is the classic appearance. 20-year-old male comes to an orthopedic clinic with a noticeable painless lump on the surface of his right femur. He first noticed it several years ago, and it has grown since then. No history of trauma that he can remember anyway. Recent changes or things like that. Physical examination, we got a bony protuberance in the lateral aspect of the distal femur. No signs of inflammation or tenderness. Range of motion is normal, no neurovascular deficits. We can consider lipoma, but again, typically lipomas don't feel firm like this one does. They are usually more hard, not so much fluctuant, but can be typically mobile within the underlying tissue. Osteosarcoma, ganglion cyst, osteochondroma, or Ewing sarcoma. Ewing sarcoma is at kind of the tail end of where we might expect it to occur, but he's much more likely in osteochondroma. These sometimes do warrant further workup, especially because it hasn't changed. It has grown in size, but there's no real underlying tenderness, inflammation, something that might need to be monitored. 19-year-old male visits with severe pain in his left femur. Has been disturbing his sleep for a few months. It's sharp, localized, worsens at night. Ibuprofen provides him with noticeable relief. That's relieving. Denies any history of trauma, no recent injuries. He's largely sedentary and eats a reasonable diet. Examination shows tenderness over the proximal shaft of the left femur, but no signs of joint inflammation or systemic symptoms. All good news. Osteosarcoma, probably not in this picture. Osteoid osteoma, it seems likely. Stress fracture, probably not. Rheumatoid arthritis, osteoblastoma. So most likely osteoid osteoma. Can be painful, but typically amenable to NSAID. 25-year-old male comes to the orthopedic clinic, complaints of persistent pain in his right tibia. Present for several months. The patient notes that it tends to worsen at night. Classic. denies any recent trauma or fractures, physical examination, localized tenderness over the mid-shaft of the right tibia. Plain radiograph is obtained. Image shows a well-circumscribed radiolucent lesion with central nidus and surrounding sclerosis. Based on the clinical presentation and imaging findings, what's the most likely diagnosis? Osteosarcoma, osteoblastoma, enchondroma, aneurysmal bone cyst, or Ewing sarcoma. Again, he's a little outside the age range for Ewing sarcoma. This is likely to be an osteoblastoma. We have that central sclerosis or central nidus and surrounding sclerosis. We don't see a lot of the changes we would expect with more malignant lesions like that sunburst pattern or lifting off of the periosteum. Now we get kind of to an important point here, counseling. So if a patient comes in and has a set of symptoms that are actually concerning, how do we go about discussing these things with the patient or caregivers? So things like growing pains, very reassuring. And we can be confident with the patients and with the caregivers like, hey, this is likely to get better, very common in your child's age group. And here are some of the things that are reassuring about it. Again, occurs at night, but is gone by the morning. Maybe occurs in the afternoon, typically better with children's Motrin if they're the appropriate age, and will not affect their gait, does not affect their ability to do activities, to play. We're not expecting this to cause alterations in the child's abilities. Providing reassurance like that is very, very beneficial to patients, and they can rest assured that what we see is typically benign. But with patients that have something that warrants a little bit of additional workup, discussing that can be a crucial process. One of the experiences I've had with a patient in the hospital was they were in the middle age range and had some of those concerning symptoms of some weight loss. The past 3 or 4 months, they'd lost 8 or 10 pounds without really meaning to. They'd had more fatigue. They'd been waking up at night with vague bone pain. With these patients coming in with these symptoms, we recognize as clinicians that there's probably something concerning underlying this. Coming out and telling the patient you have cancer is inappropriate. For one, we don't know that quite yet, though our suspicion is high. But glossing over it and saying, you know what, it's probably nothing, but we'll do some workup, sets the patient up for probable disappointment because our clinical suspicion is high. So what we typically would do with patients like this, at least from my experience and some of the preceptors I've observed do this well, is setting expectations, saying these symptoms are concerning. We're worried that there's something underlying this that's serious. What we want to do is do some additional workup, find out where we stand, but no reason to panic quite yet. Let us get all the facts together and we'll get a plan of how we can go about finding out what you have and what we can do to treat you. This provides patients with a lot of hope. They recognize that you are being honest with them. You think there is something serious at play, but you're not telling them terrible news that they now need to despair about. You're saying, here's a plan. We're going to approach this clinically. We're going to find you answers. And then ultimately, we're going to get a plan together for what we're going to do for you going forward. We'll call the appropriate consults and we'll take care of you. Ultimately, what they want to be told is that they will be taken care of, that we have a plan, and that we are going to be honest with them throughout the process. For lesions that have a high probability of malignancy, things like the patient that came in that I told you about, who had the numerous lesions in her brain, we approached it a little bit differently than that because it was almost a certainty that she had metastatic disease of some sort. So our approach was what they typically say, set the tone, set the scene, kind of ensure some privacy, and be very direct and very confident, and prevent the patient with the facts and with the plan. So in the hospital, we sat in her room, we closed the door, and I had the opportunity to discuss her care with her. And I said, so for the past couple of weeks, you've been having this dizziness, this loss of balance. And those are, not fun things to deal with. And I'm really sorry you've dealt with that. But
the scan of your brain has some concerning findings that I want to talk to you about. I think it's bad news. I think that what you have is probably some kind of malignancy that started somewhere else in your body and has migrated to your brain. I don't know for certain what kind it is, but my suspicion is high that that is the process that's going on. And our radiologist agrees. So here's what we want to do. Right now, we don't have answers. We have a lot of questions, and I know you do too. What we're going to do for you is we want to do some additional scans to clearly identify what we're dealing with, and then probably get a tissue sample so we can characterize it and call appropriate professionals who deal with this sort of thing every day. We'll be here with you every step of the way, but we're going to call people who this is their lane, this is their specialty, and then we'll coordinate care with them so that you are taken care of. What questions do you have about this? And so she was able to ask her questions, and she handled it very stoically, and we treated her appropriately. Turns out, as I said again, that she had small cell lung cancer that had metastasized to her brain. And we began treatment with her. We called the appropriate consults, and the whole step, every step of the way, we were honest with her. We were clear about things. We're generally positive. We don't have to be somber. This isn't something that needs a lot of sorrow. We don't have to put on a sad countenance necessarily with our patients. It would also be conversely inappropriate to be overly boisterous and happy and bubbly. We have to find an appropriate middle ground in delivering bad news. But I think that's the process of a lifetime for clinicians. Then there are other conditions that can cause bone and joint disorders. They can cause bone pain that are not necessarily lesions in the bone, but rather inflammatory conditions, systemic inflammatory conditions. Lupus is a classic one. We had a patient in the hospital come in with very vague symptoms: abdominal pain, nausea, vomiting, joint pain. Inflammatory markers were elevated, but rheumatoid factor was not. CRP, ESR, things like that. And ultimately, we had to call a rheumatology consult who diagnosed her with lupus. Rheumatoid arthritis, that can cause joint pain and bone pain. Ankylosing spondylitis is a classic one for the lower back and the SI joints. Osteoarthritis, DISH, leg calves purse disease, reactive arthritis, transient synovitis. Having a list like this in your differential helps you go through when you have a patient come in with complaints about bone pain. We begin at the start. We say, tell me the history, systemic symptoms. Are there other things at play? Do we have lab results that indicate maybe an inflammatory process? So it's not always necessarily a primary bone lesion that's causing the bone pain. Sometimes it's a systemic condition instead. This is an interesting one that was introduced to me by a radiologist. This diffuse idiopathic skeletal hyperostosis, often seen in the spine, but can infect other joints as well. So something different from spondylosis would be that we do not have degradation in the height of the axial skeleton. There's not ankylosis. This is more that you have connections between the facets due to chronic inflammation. Classically, this one has normal lab values. On contrast, ankylosing spondylitis has very abnormal lab values. HLA-B27, from those of you who remember step 1, can happen in young adulthood or middle age. A friend of mine had this actually, and he was in his early 20s when he was diagnosed. There are other associated syndromes or symptoms that can occur: aortic regurgitation, fibrosis. The consult to rheumatology is a good idea. Leg calves purse disease. This is one that's not to miss. So young people who have gait changes with their bone or joint pain need further workup. So this is not growing pains, though it probably is associated with growing. But this is classically, osteonecrosis of the femoral head. And the cause of this osteonecrosis is not well understood necessarily. There are some theories as to why it occurs. Sometimes it spontaneously resolves before there's osteonecrosis, but the pain comes, the pain goes. And these patients have typically long-term consequences. Sometimes the repair of the bone, as blood flow returns spontaneously, you have remodeling of the head of the femur, and it no longer sits well in its joint space. That's one of the better outcomes. Worse outcomes, they have chronic debility and severe limitation of range of motion and function. But the one thing to be aware of with this, we have patients who have leg cavity Perthes disease or just Perthes disease. They often can have recurrence on the contralateral side. So maybe they've recovered from their initial bout on one side, but we need to be aware that recurrence rate is fairly high for contralateral disease. And then Reiter syndrome or reactive arthritis, inflammation that occurs after infections, typically gram-negative bacteria. Sometimes sexually transmitted infections can cause this as well, but it's usually asymmetric, and you have associated symptoms of urethritis. Sometimes it causes inflammation in the eyes as well. But treatment is usually the underlying infection. So you treat the infection and the symptoms should improve as well. The inflammatory process can be robust, and sometimes you need DMARDs or steroids, but usually this will improve and won't have lasting effects. Though sometimes you can have degradation of the bone itself or the joint capsule. In that case, you can have chronic consequences, but not all the time. And here's one that we'd have to differentiate between Leg-Calves-Perthes disease and transient synovitis. Hip pain in young children that's usually self-limited, but it can be associated with viral infections. So the patient has an upper respiratory tract infection, they've got sniffles, they've got the cough, and then they develop pain in their joints. So usually this, again, is amenable to conservative measures and doesn't really require aggressive workup unless it doesn't improve. And then we want the patient to be further evaluated for maybe some other underlying cause. Again, self-resolved. Sometimes it'll go after just a few days, but may linger a bit longer. So a couple more clinical vignettes for us, just to get a little bit more practice putting together the clinical pieces. 32-year-old male comes to clinic with a complaint of lower back pain and stiffness. It's been gradually worsening over the past several months, notably more pronounced in the morning and lasts from minutes to hours. Stiffness over his lower back and hips, particularly if he rests in activity. No recent trauma, no injuries, on examination, there's limited range of motion of the lumbar spine and he has difficulty bending forward. No joint swelling or redness. Everything else is normal. Most likely diagnosis, he's kind of in the age range where he could have early onset osteoarthritis, depending on his BMI, family history, and what he does for work. He could have disc herniation, but it's a little bit different than both of those. Classically, though not all the time, osteoarthritis is worse with use, better with rest. Inflammatory arthritis, such as ankylosing spondylitis, is typically worse with rest. Similar with rheumatoid arthritis, patients can get better as they work the joints. Laboratory findings that are elevated in this patient: SSRO and SS-LAW, probably not those. CRP, the catch-all for inflammatory disorders, will usually be elevated. Some of these other ones can indicate RF, lupus. Young child, 3-year-old, brought to clinic by his concerned mother due to persistent and reluctance to bear weight of the left leg. He had a minor fall at home a week ago, but did not seem seriously injured at the time. His discomfort has increased, particularly during attempts to move the leg. On examination, he is visibly distressed and there's tenderness over the mid-shaft of the left femur. He resists any manipulation of the left leg, and radiography reveals a recent spiral fracture in the left femur. Which of the following is the most likely explanation for the child's symptoms? Oh, explanation, I have a bunch of workup. Questions wrong. Which of the following should you do? Initiate a trial of physical therapy, arrange genetic testing, order a bone biopsy, report to Child Protective Services, and prescribe anti-inflammatory medication. This one is concerning for non-accidental trauma. So a minor fall perceived minor injury, really no big deal. And then the child has worsening symptoms. And radiography, we're not seeing malignant changes here. We're not concerned about some primary bone tumor. We've got a spiral fracture in the left femur, and that's hard to do, especially for a kid. Oftentimes, these young bones are very malleable, and we'll have something like a green stick fracture with typical use if children are doing things that children like to do and jumping off the jungle gym, crashing down off the slide in a weird way. They can have green stick fractures. Spiral fractures a little bit more difficult to achieve, and oftentimes is associated with non-accidental trauma. So bottom line for young patients, or on the flip side of things, elderly dependent adults, if we are concerned about unusual fractures, for instance, a bed-bound patient in her 60s who all of a sudden has a femur fracture, or rib fractures, or a young child like this who has really not a great history of trauma, but concerning suspicious fractures, this has to be reported, and we are obligated to do so legally as well as morally. And then Child Protective Services will get involved. The law enforcement authorities will do so as well. And the workup will be extensive, bone scans, things of that nature. So that's all I had as far as my lecture for today. And I think we were going to questions, if there are any questions or talking points or discussions or even corrections. If you have ideas about diagnosis, appropriate workup, further ideas about counseling patients in difficult situations, or things like that, feel free to vocalize them.
Thank you, Dr. Lemon. If people have questions, feel free to type them into the chat or unmute to ask your questions directly. Any comments or questions? Of course, I get a phone call right then. Well, an excellent lecture, Dr. Lemon. Thank you on this important topic. As I stated before, we have information on how to get the CME in the chat. So either fill out the Google form or email me. All the information is there for that. I will be posting the recording of this presentation in the IAFP CME library. So you go to publications, and at the top of our publications page at idahofamilyphysicians.org, there's a link to our CME library. You will not be able to get credit for viewing it later, but you can access all the excellent information that Dr. Lemon shared. And our next Grand Rounds presentation is taking place on March 10th. And it is with which program? The ISU program. And that title is Understanding Common Toxidromes and Overdoses in Clinical Practice. So that will be another interesting topic. Dr. Lemon, is there anything else you'd like to share?
Oh, thanks for being here.
Well, thank you again, and we appreciate everybody's time, especially you, Dr. Lemon, and we will see you again next month. Have a good day.
Thank you.